taking us through how we've been able to optimize health resources as an organization. Evidence suggests that inefficiency is one of the major factors impeding access towards achieving universal health coverage. It is also known that about 20 to 40% of health resources have been wasted due to inefficiency. A recent study in 2023, to be precise, assessed the efficiency of health system towards achieving universal health coverage, garnering evidence from sub-Saharan African countries. So that research found out that for lower middle-income countries, we can actually improve our UHC score by 13.6% without actually increasing the health resources at our disposal. So that takes us to looking at the angle of optimization. While we advocate for more health resources, it's also important that we look inward to assess the extent to which health resources are being utilized to give us value for money. All right, so I'll be taking us through how we've been able to do this as an organization, guided by the outline above. So who are we as DGI? DGI means Development Governance International Consult. We are an indigenous organization, a purpose-driven governance, institutional capacity strengthening and research consulting firm. We are for profit, but we also have a not-for-profit arm known as the DGI Foundation, the Development Governance International Foundation. We promote the use of evidence to improve governance in terms of policy making, institutional reform, coordination, collaboration, and accountability towards ensuring expanded access to social services with equity. We are guided by the principle to drive sustainable solutions with excellence. We have worked in over 20 states across the six geopolitical zones of the country, and we are currently implementing projects in many of these states. Our head office is situated in Abuja. So as I mentioned, when we talk about efficiency, efficiency could be looked at two angles, from the aspect of technical efficiency and allocative efficiency. In other words, having us do the right thing and also doing things right. So it's important for us to generate evidence when we are talking about optimizing health resources. So how have we been able to do this as an organization? We've been involved in a couple of areas of work, which I will briefly take us through this morning. First is the health financing analytics. So we know that in the health financing space, we clamor for inadequate funding for health and all, but how have we been able to use evidence in improving this? So we've done this through a couple of analytical work, a fiscal space analysis, political economy analysis, costing and financial modeling, as well as surveys. So for the FSA, we've identified sources of innovative funding for different program areas, as I have listed above. For the political economy analysis, we've also helped in identifying the effect of interplay of different institutions and actors towards the implementation of different programs and policy trust in the country. Currently, we are also working on development of a comprehensive financial modeling for sexual and reproductive health rights to help us identify projected financial requirements towards expanding sexual and reproductive health rights at the national level and also at the subnational level. We've been involved in a couple of surveys for the Yobe State Health Contributory Management Agency. So of them identify gaps in their implementation and also hear the perspective of their enrollees and providers towards ensuring that the agency improves in its operation. So in all of what we do not just only generate evidences, we also follow up to ensure that the evidence generated have been acted upon. A peculiar one is the evidence generated during the conduct of the fiscal space analysis for family planning in year 2021. So we're able to identify that lower middle income countries like Nigeria are actually allocating and releasing not less than 1% of their health budget for family planning. So that brought about our recommendation, which was followed by active advocacy efforts, which also led to the engagement of the Federal Ministry of Health, and they allocated 1% of the annual budget to family planning at all levels. It's also noteworthy that during the FSA for YSCHMA, we're able to identify adoption as a model for expanding health insurance coverage to the poor and vulnerable, which led the agency to engage in the Bill and Melinda Gates Foundation, which brought about the adoption of over 1,000 lives of poor and vulnerable persons in Yobe State. So we are not restricted to health financing analytics. We also look at other areas of work. Recently, we're engaged by the Bill and Melinda Gates Foundation to help them develop human resource for health strategy. Guided by the principle of evidence, we embarked on conducting a situation analysis for human resource for health landscape in their 10 focus states. The analytical framework for this research actually was premised on the fact that HRH governance, financing, and political economy actually drives the efficiency and effectiveness of core HRH functions, which in turn has an implication on HRH optimization and in turn service delivery. And when we talk about HRH optimization, we are basically looking at how to get the best out of human resource for health, given a fiscal context, to ensure that we have the right number of health workers at the right mix, in the right place, and also with the right performance. We also did a private sector landscape assessment for DHI rather, to identify areas of collaboration with the private sector towards enhancing sustainable financing for epidemic preparedness and response. We also did a gap analysis for the state USAID funded projects state to state. In addition to our analytical work, we are also known for organizational capacity strengthening. You agree with me that weak organization capacity strengthening actually has an implication for how resources are being optimized. It has an implication for how the organization plans, coordinate, and also execute. And when we talk about resources, it's not just limited to money, both man, money, and materials. We helped a number of state social health insurance agencies in the country during their pre-implementation stage to build their capacity and also help in the development of tools. However, most recently, we were engaged by the USAID LHSS project in their supported state to support the state health insurance agencies and primary health care board. Guided by the principle of evidence, we embarked on conducting an organization capacity assessment, which looked at 12 dimensions at the area of technical capacity, organizational development, financial management, business plan, as well as compliance. So during this assessment, we're able to identify the critical capacity gaps in these agencies, and we tailored the capacity strengthening plan to those gaps. So we conduct organization capacity strengthening based on a tripod approach of technical competency and leadership training, as well as system and tool design. We do not just leave the organizations alone. We know that there is a need for hand-holding, a focused and hand-holding moment to ensure that the identified gaps are actually breached. The project is still ongoing, but what does success look like? It's our expectation by the end of the implementation of this, we're able to see improvement in management practices, improvement in partnership and coordination, as well as enhanced technical expertise and capacity building. When we look at a lot of managerial capacity building, they are usually above sites at the organization level, leaving behind the frontline health workers who are actually utilizing these services. A lot of money has gone into the primary healthcare system to ensure that we have improved primary healthcare system. Talk about the basic healthcare provision fund, the drug revolving fund, capitations being received through state health insurance agencies, and recently, money from the impact project. So it is important to see how at the facility level, these resources are being utilized to achieve value for money. So we're engaged on the USAID integrated health project to build the capacity of PHC staff on facility and financial management in the 6 area councils of FCT, focusing on the 70 first generation USAID IHP supported facility. We also used a tripod approach to deliver this. We selected and trained personnel from the state health parastatals, and the rationale behind that is to ensure sustainability of this beyond USAID IHP and even beyond DJI consults, so that there's ownership within the system to be able to scale this up. So following that, we then embarked on a step-down training of the officers in charge, the Ward Development Committee chairman, and even the account clerk of these facilities using a training manual that was developed by the MPHCDA with support of YSCHMA. Again, we didn't just train one off and leave it at that. We also embarked on a focused mentoring of this facility, which is going to happen for 3 consecutive months to ensure that all of the best practices that they were taught during the training are actually being implemented in the facility. We have started seeing emerging results. We are not there yet, but we have started seeing changes. We have seen the WDC chairman holding up to their responsibility, looking inward and mobilizing resources within their community. We have also seen the OICs improve in their managerial functions, being able to manage the inadequate human resource for health existing at that level. I would also implore us all to look at the first pages of our diary, which I believe will be passed around to engage in details with all of this work. Moving on, we also worked in the area of domestic resource mobilization and utilization in the face of dwindling donor funding for health in general. And for this particular work, we're looking at TB. So we, guided by the principle of evidence again, we conducted a public financial management assessment to look at the trend of TB budget allocation and releases over the states in the implementing states. This is also a USAID funded project, TB Loan 1 and 2. The states are listed above. So based on the gaps we identified, we were able to tailor our interventions to address all of these gaps to ensure that there is increased budget, release, and even utilization, because you tend to see that a lot of issues around absorptive capacity of MDAs actually has to do with technical capacity. It is only brilliant minds and capacity that are able to utilize resources effectively. I would like to draw our mind to that figure above. It's just showing the trend of TB budget release in Lagos before that intervention. And we can see the multiple fold in the increase of TB budget. And lastly, we've mentioned in the course of our discussion this morning about how we need to get to the grassroots. It's known that the group of people who are usually not inadequately carried along in the design and implementation of policies, actually the community members, the people at the grassroots. So to optimize resources, it is important for us to also strengthen our community system. So with the funding of the Christian Aid UK, we're able to embark on a project to look at how we strengthen community system. We also did a baseline which guided our interventions. So using basic healthcare provision fund, for example, a lot of money is going into there, and the final users or the end users of this fund are actually people that go to the facility to access care. But we have seen that the gap in carrying along the community members actually have implications for how that resource is being utilized. So based on this project we carried out with the funding from Christian Aid, we adopted a 440 persons on the state health insurance scheme. That's National State Health Insurance Scheme. But we didn't just adopt and leave it at that. We strengthened the community by identifying volunteers who we trained on what basic healthcare provision fund is, what health insurance is. So they were able to champion this cause at the community level. And we also combined effective community engagements with it. So based on that, we try to look at what's the difference between the enrollees of that particular project, enrollees of basic healthcare provision fund, equity fund, and even people that are unenrolled. So we realized that there's higher consultation per person per year, meaning that we have more persons going to the health facility to access the care they need in the cohort of people who were adequately engaged, compared to basic healthcare provision fund, compared to equity fund. And we can't even compare that of unenrolled patients because it's less than 1 consultation per person per year, which actually negates the 4 consultations per person per year if we want to talk about achieving universal health coverage. We also built the trust of community members. There have been previous government interventions that have started and failed, which actually destroyed the trust of community members. But with this project, we're able to build that trust. And what we're able to see is community members themselves asking, demanding for healthcare services. They are going ahead to meet influential persons to adopt poor and vulnerable persons on health insurance scheme. And we had a major result of 145 persons adopted by community members within the community on health insurance scheme, having understood and also seen positive results from that. Monthly meetings, effective community engagement, those are the things that actually accelerated the success of this project. We implemented in Nasarawa State, but currently the project is being scaled up to FCT, and we are currently working in 2 area councils of FCT, and there's also a nutrition component to the work. So as DGI, we do not work in silo. We also collaborate with other organizations in the space to achieve the optimization of health resources. Major of our work is around accountability, which we're actively involved with the Health Sector Reform Coalition in development of a citizen-led accountability framework for the Basic Healthcare Provision Fund. Also involved in development of accountability framework for epidemic preparedness response. So all of the things I've said have only been made possible by our clients. Our donors are implementing partners who have provided the wings for us to fly and also to showcase our technical capacity. We, on behalf of the entire team, I appreciate you all. So the brain behind the delivery of this technical assistant and program management, I have only mentioned some of, actually highlighted above. So thank you very much.
Thank you very much, Sekinat. This speaks to the volume of work that's being done by DGI Consult and the consistency with which they have continued to build on health programs. It's one thing to start a program, it's also another thing to build on a trajectory and follow through and ensure that there is impact and that you can demonstrate that there is a visible change. So thank you so much to DGI Consult. We will take the next presentation, which is something that we all talk about. Maybe we talk about it a lot and don't do much about it. And so online this morning, we have Professor Dina Balabanova, who is a professor of health systems and policy, London School of Hygiene and Tropical Medicine, who will be talking to us on curbing corruption in the health sector. What have we learned? If we can tackle corruption, most times we believe we can solve 80% of the problems around ensuring efficient use of resources. We're better able to optimize the resources that are being allocated in the health sector. We'll see more results. We're not looking for more money, but better use of whatever resources are available. So this morning we have an opportunity to talk about curbing corruption in the health sector and what we have learned about curbing corruption or trying to plug wastages, ensure better efficiencies, and ensure that the system is more effective. Welcome, Prof.
Good morning. It's a pleasure for me to join the meeting. I wonder whether you hear me.
Yes, we can hear you, Prof, loud and clear.
And can you see my screen?
Yes, we can, Prof.
Okay, so it's a great pleasure to be here. I've been working in Nigeria for the last 7-8 years and really observing the amount of investment, the amount of interest, and the amount of interesting initiatives that are happening. I think this is such a great place to be. But one thing I would like to talk today, and that's not just Nigeria. I'm going to start with the global picture and then go to Nigeria with some examples, but really thinking about how can we maximize the resources that are coming to the health system? How can we make healthcare more accessible, higher quality? And one of the kind of big areas that only in the past 5-6 years we're talking about more internationally is corruption. So this has been not a topic that was discussed before. And even now, there is a lot of reluctance. We hear a lot of international actors would say, well, if you increase the resources in a system, the money will allow for the system to improve and corruption will disappear. I can already tell you from analysis that we're doing in other countries that have expanded coverage, universal coverage, that this does not happen. Corruption transforms. I don't know whether you know, there is enormous corruption, even in procurement, for example, in UK, in Germany. So this is something that we need to tackle. I would like to talk today about that. So first of all, I need to convince you that this is an important issue, and this is a summary of that. First of all, there are different estimates varying between 7% to 40% of all health resources lost to corruption. You all talked about the targets, 15% of the budget, government budget for health. But when you think how much is lost and how do we improve the efficiency? So this is quite a huge loss. So a recent study that we did in Uganda showed that 26% of the public health budget is lost to corruption. The outcomes, there are a lot of studies that are documented impact on outcomes. For example, there are several studies documented impact on maternal and child mortality. One study showed that 140,000 annual deaths among children per year could be attributed to corruption. NCD outcomes, so NCD is a big issue everywhere, and often it's chronic disease requiring to have expenditure for life, so catastrophic expenditure. So again, the outcomes are influenced. So we should be worried about that. Again, equity. So what's interesting, there is a lot of debate, the rich people pay more, but I can already tell you that a lot of the kind of studies are showing that that's not the case. It's the poor who pay more as a proportion of their income, the poor who are affected in terms of the access to healthcare. Another area of problems is the system damage. We should be worried about the damage to the health system, where there are investments coming into the system to expand coverage, but at the same, even when you have social insurance, you have insurance fraud, you have kickbacks for pharmaceuticals, informal payments are very common. So I think this changes the incentives and the goal of the health system. Again, this is something that we should be worried, but some of the drivers I would like to talk today are that one of the kind of hallmarks of our approach has been to not to talk about individuals and punishing individuals. A lot of the effort so far has been around that. How do we catch and prevent that? But really, how do we change systems? And my colleague who is in the room with whom we prepared this presentation, Prince Wu, just published a paper which is called Systems, Not Individuals. It's really thinking like, what are the health system determinants of corruption and absenteeism in particular? And how can we address those instead of going and doing catching individuals? And this is rarely possible and very efficient way of doing things. Again, I'm going to talk about the political drivers and the way we understand the role of networks. So what is the state of knowledge? If I can give you the definition we've been using. So of course, everybody knows the definition, Transparency International, abuse of entrusted power for private gain. However, we have found that a more expanded definition is more useful because it's often not just private gain. Sometimes it's institutional gain, also in the public sector. So I think this definition I would like to offer to you: the abuse or complicity in abuse, power and authority to materially benefit oneself or a group in a way that diverts institutions from their core aims. So that's a definition we've been using in recent studies with our team in Nigeria as well. So what are the important things to remember here? So corruption is not a moral issue. It's not a failing individuals who are not doing the right thing. It is also about the systemic and power factors. Very often individuals who are in particular environment have little choice than to go along with what is going on. They don't have the power to change things. Again, we have a lot of fluidity around corruption, very often what we call survival corruption. For example, absenteeism, there are situations where people don't have transport, there is no security, so they're absent because they have to be absent, or they have to go somewhere to earn living wage. So involuntary rule breaking, where the rules are not clear. So clearly this is a systems problem, or inefficiency. And then, however, what we are finding in a lot of studies, that when you have a lot of these informal practices, inefficiencies, coping strategies, you end up with a space where corruption increases over time. So that's something that we think it's important to monitor. And so really, so in our work, we've been thinking what shall we focus on? And I think I would like to argue that we should focus on practices that cause most harm, because there are very often situations where people break the rules, and they don't do that because they want to do something bad, they want to deliver services, but sometimes rule breaking is harmless. So we shouldn't focus on all rule breaking. We should focus on places where there is most harm. This is just an overview. I'm not going to go through all this. This is from studies. This is what we know are the drivers of corruption and rule breaking. Politics, people who are protected from patronage, tolerance to rent seeking, which very often has political determinants in the political economy locally. Then the economics, the fact that the health sector is underfunded, the health systems that are poorly governed, then unclear rules, lack of regulatory effectiveness, also social norms and social networks. I would like to make a really critical point here that corruption is never individual. This is not rule breaking by individuals. It is always networks. It's always, so for somebody to be absent from their work, for somebody to take informal payments, there are a lot of other people who know what is going on. So that's what we are finding. It's not just Nigeria, it's a lot of countries. It's in high-income countries as well. So it's really important to think about these networks, and socially, very often there are social kinship networks and so forth, reciprocal. So in Malawi, for example, when people go to a facility and they ask the cleaner to give them medicines from the cupboard, they do that, and the cleaner cannot say no because they're in a kinship network, or their community and neighbors, they know this person is suffering, so is this corruption? So there are a lot of borderline issues here. Again, values and social norms, sometimes just practical norms. People want to benefit their family, but in a way, if you remember the definition I gave, it is diverting the health system from reaching its goals. So for example, maybe somebody will benefit who is also poor, but maybe somebody else who needs the service more is denied this service. Again, some of our colleagues here from the team, Charles Ogokor, published a paper which is talking about the local narratives. And interestingly, we've seen studies from different countries that are showing that when you have corruption, campaigns anti-corruption, actually corruption increases. And why is that? Because people feel it's hopeless. Corruption is everywhere. So there is this local narrative justifying it. Health workers, they don't have resources, they have to do it, they have to take informal payments. So I think it's important to understand the local narratives. So I would like to really talk more today about solutions. So what do we know about solutions? And my simple answer is we don't know much. We don't have very many studies that have actually implemented something. There's been several systematic reviews that found almost nothing that was sustained over time, nothing that was institutionally embedded. For example, there are a lot of solutions that are done, digital solution or something locally with a lot of local ownership, local citizenship, but they're not at scale and they're not integrated in the health system. So we can't replicate them. So I think this is a real problem. And we have been, and I will tell you in a minute about the solution we'll be implementing with Princeton University of Nigeria this year. So what we find is every country has a blueprint or some sort of national strategy, anti-corruption or regulations at national level. And very often there are local solutions where there is a lot of political will, but it's hardly anything that's properly documented and clear of why it works. So this, I'll draw insights. I would like to tell you a few things based on these two projects, Accountability in Action, which is in Nigeria, and the ACE, the Anti-Corruption Evidence Program, which has generated a lot of evidence over the last 6 years. As I said, we have a lot of, if you see one of the columns is harm, is something harmful. For example, a lot of people in Nigeria or in other countries do various things in the health system informally, but it doesn't mean that it's harmful. Sometimes it's just to get things moving, to ensure that sometimes the systems don't work well. So people are finding ways around it. At the same time, some of these practices are illicit or illegal, and some are legal. So what we have found most useful is to focus on those practices that are harmful, that cause most harm in terms of outcomes and in terms of access to care, but they're also illegal. So I think this is the first step when we try to curb corruption, because if we start to deal with other things, for example, these are, for example, legal practices, but they don't lead to good outcomes. This is a completely different issue. So we should really focus on where is the harm. And I would like to just mention work on absenteeism by our team. So led by Charles Ogokoro and Prince and others. So we know absenteeism is rife. So data showing that in some cases it's 70% of the health workers that are absent at any time in facilities in Nigeria. But this is also in other countries in sub-Saharan Africa. I wouldn't want to just say it's Nigeria. It's not true. So it has high impact at individual level, but also at community level, at health systems. And during outbreaks, we see particularly this. But also, when we think about maternal and child health or key services, inability of people to get care and communities to get preventative measures on time. So what are the issues? So we have here, our research is showing that there are different factors. So powerful actors, for example, that influence employment of people who are never going to stay there, people who very often leave their post, protectionism. So people have protection, they're not punished if they're absent. System-wide inefficiencies, lack of good supervision, effective supervision, and irregular employment. So what happens very often when you have absent health workers, what happens? So we have written a paper about it. And I hope in the human resource strategy you covered that. But what happens? The facilities employ volunteers. These are trained workers who are not employed, they are informally employed, and they have salaries very often paid from informal payments. So the facility generates resources and they pay these volunteers to cover, very often for health workers who are formally employed, but they're not in the facility. They're absent. Against social norms. So we've written several reports, which I can share, that especially for women, so very often there is a lot of pressure and expectations. They have to leave the post because of childcare, or they have to earn money somewhere else, also men. So I think there are a lot of kind of social and communal practices and pressures on doctors. Doctors are not just doctors, they're also individuals, they're part of families. So very quick one, we did a prioritization with policymakers a few years ago, and absenteeism was seen. So we ranked in several kind of stages using nominal group technique methods. And as you see, from between the first and the second stage, absenteeism was ranked as #1 priority to address, because you can't have functioning health systems if you have absenteeism at that level that we see in Nigeria, in parts of Nigeria. And then things like procurement was initially seen as a big problem, but when people ranked it in terms of harm, but also in terms of ability to address. So as you see, absenteeism remains something that the policymakers and practitioners felt we can address. We had also a lot of CSOs representing communities, so that was seen as something we can address. But procurement was seen as less likely to be able to address in the short term. So why is it so difficult to address absenteeism? I think everybody in the room knows that this is a pervasive problem, and it was mentioned by some of the esteemed speakers already. The lack of clear rules, service, as I said, people use different health providers to cover the gaps, and we really, sometimes people don't see who is who. So it's difficult to make the health workers accountable. So sometimes if people are providing services, but these are volunteers, these are not the health workers who should be there. The rules and regulations are often unclear. There is a broad framework of what is for example, the civil code. We all know the civil code in Nigeria regulates how people should work in the public sector. However, it's not operationalized. Very often, if you ask the majors, where is your SOP, the standard operating procedures, they don't have that. There are no clear rules. Very often, this was a very interesting example where the World Development Committee Alliance in Kano, they are very active. So for example, they're incredible example. We are studying them. Somebody said we should study positive practices. This is a fantastic example of positive practice where community members report to the WDC Alliance in Kano, and they go and talk to the commissioner, they talk to the health system managers, and really try to take action. However, there's been cases where people would raise complaints. However, after that, after discussion, the communities and complainants decide to withdraw the complaint because the feeling is that health workers are part of the community. People don't want to see them punished. All people want is somebody to be in a facility, not necessarily to punish. That's why I think this focus on changing systems, not punishing individuals, is really important. Because very often people don't have choice. They have to go along with this practice. So what can we do? And I'll tell you, this is something we'll be doing this year as a small proof of concept, because as I said, there is nowhere in the world that they've done successful intervention for absenteeism that's sustainable. So we think it's going to, intervention for absenteeism could work at 3 levels. We're going to do it in the state of Enugu and Kano. So we think it's going to be definitely something at facility level. So we're going to have a process of co-production. We are very much going with grassroots and what practitioners and managers and communities can design together. So it would have local enforcement, it would have community oversight, some sort of link to local governance structures. And very important, we need to link to structures outside the health system, not just in the health system. Health system often is not enough. We need to think who are the powerful actors locally who can make a difference. And this is showing, our studies are showing that these are the people who can make a difference and who are the alliances. At district level, we need to have a little bit more, perhaps, flexibility. The civil code says that providers cannot leave their post, even if they have family issues or problems. There is no flexible working, part-time working. So maybe we need that. Maybe we need flexibility so we can reduce the involuntary absenteeism and just address the harmful absenteeism. Thinking about incentive packages, we're thinking of a small incentive for providers for childcare, for example, and for transport that would allow them to really be there on time in their work hours. And at national level, to really try to link to policy dialogues and to the human resource strategy and think what needs to change in order to improve career pathways for those who are not employed, or improve the training opportunities of growth of those who are employed, and enable them to have a better career progression and motivation to stay in their post for the period they're employed. So this is what we hope to do. But I just want to say a few words very quickly about informal payments. Another series of study that was again published recently by Pamela Bozor and the Prince and the group. Again, we have informal payments. I'm not going to go through this because I feel I'm running out of time, but I just want to tell you that informal payments are extremely common. We just did another survey. We observed, our team did a lot of work in different facilities. And basically we are discovering, and this is very much compliant with what we see in other surveys. So we see a lot of payments. We see payments for services that should be free, for maternal and child health, routine immunization. People contribute. And what is really interesting, very often this is seen as almost discretionary. And even some providers told us, people can pay, it's a tiny amount. But we had health users who say, no, I can't. I have to go home. I can't pay that. So it's really, people they have to sometimes not do it. They can't afford lab services where sometimes the fees are high, birth certificates, delivery. So I think we have a lot of that, and I'm very happy to share the paper that we published right now. But it is something that we have to think about, because if we are providing free services, universal coverage, expanding coverage, what is the point if the poorest people, they're the ones who cannot pay? Very often the people with more money, they can negotiate their way through, but the people with less resources, they can't. And we even had one officer in charge who told us, we said, what about people who are rural? They don't have the money. And she said, actually, they have to find the money. That's what it is. We can't exempt. So I think this is, and a lot of this is informal. We know that, because payments for this for some of these services is by regulation people should not pay. I'm not going to go through this, but we have mapped, and we have several papers where we have mapped kind of the driver of the informal payments. For example, the lack of receipts. This is leading really to people not paying, that don't know what they're paying. We now a survey, we ask people, did you get a receipt? Do you know what you're paying for? People don't know. Massive amount are saying no. So really, it's rent seeking and it's very rampant. So this is affecting mortality and morbidity. And so somebody mentioned the digital health, and this is extremely promising. We need to have a system. I know that in many countries we have system for ranking restaurants, for ranking hotels. Why can't we have this for ranking? I know in Bangladesh did something like that. They rank facilities. So you go to a facility, you ask to pay, you know for sure this is not, you just post online. And these are the type of things we can start thinking about. How do we do it at the same time, not penalizing? It's not about penalizing. It's really enabling better access and better functioning. If a facility has massive funding gap, let's try to signal this instead of asking users to contribute. Maybe there is a way around that. Or if there are not enough health workers, and this leads to employing volunteers, so why can't we transform these volunteers? They're trained. Why can't we find a way, career progression, where they can be initially employed as help or something, and they can gradually grow? Again, the kickbacks, they're daily to catastrophic expenditure, and this is something that we need to have the clear sanctions, because there isn't clear sanctions. Very often, even district level is kind of keeping quiet because they know that's the only way to sustain the healthcare locally. So what is the key message? Very often informal payments are not requested by evil people who want to do bad things and to reduce access. This is because they need to make the system work. They don't have often choice. But very often it is becoming kind of, this is what my colleagues call it, racket. It's really to the detriment of the vulnerable people. And when we think of pragmatic approaches to deal with informal payments, our suggestion is that this needs to be about clear rules, public awareness. There should be a list of what you have to pay for in every facility, and it's not there currently. That's not expensive to do. And there has to be oversight by trusted parties, not by somebody who is necessarily in the health system, but by trusted parties, WDCs or any other structures locally, with support of powerful alliances. If we don't have the political support for these people who break the rules, it's not going to work. So that's our big conclusion. So we have here done work on, again, we use the principal agent here. I think I'm going to stop here just to leave you with this. We really want to say that in order to curb corruption, that was my topic for today, we need to engage actors who are powerful enough to make change, to make decisions. But also we need to political economy, the frameworks we use by Khan and Roy and other scholars, it's really saying that we need interesting actors. So we need powerful actors who are interested. There are people always who benefit from anti-corruption measures. For example, they benefit from having their constituency be having better access to services. We need to involve people like that. We need actors who have capability to do the measures that are needed. So these are the three things that need to happen. And very often we have to go beyond the health system. And so that's something the health system governance should be better at doing. And the grassroots approach is very promising. I think that's one area globally that we see happen in Brazil, in Bangladesh, a lot of countries. I think doing something at the grassroots as an oversight or empowering is really awareness, can do something, and this could be used in the health system. So I'm finishing here. To curb corruption, what can we do? We need to talk about what exactly we are addressing. We shouldn't just go and address everything. We should address what's most harmful. We should prioritize what's politically and institutionally feasible. And also we should look for good practices. There are a lot of good practices in Nigeria, which we are studying now. We should find these good practices. We call them islands of integrity. We should find them, map them, document them, and make them. And maybe DJI Consult can help us to do that. We did a few times global crowdsourcing and said to people, just give us good examples. So identify actors and really try to find these informal actors who can help, who play a key role. And this is in every area where we spoke to people. They would say there are local actors who are really supporting us. So we need to work with those and address them. and really think about the root causes in the health system and engaging with the politics. And finally, this is something that we've been working with WHO currently, trying to talk about prevention of corruption, not curbing. Once corruption is entrenched, it's entrenched. What can we do to prevent further? And working with young doctors, working with young people in the community, we can change the mentality. We can do something different. So, and finally, I just want to, if you want to get involved in this topic, if you're passionate about this topic, please welcome. So there is several opportunities. This we just established global network on anti-corruption, transparency, and accountability in health. So that's involving WHO, the Global Fund, World Bank, UNDP, lots of donors and funders and government representatives. So you could find a website with resources, opportunities to get involved. Again, this is the project I mesh. This is the thematic working group on accountability and anti-corruption for SDGs. Anybody could become a member, and I'm going to post in the chat or distribute via DGI the website. Please welcome, and you could join for free. And there are lots of funding opportunities, discussions, and thinking about country experience. So this is our team, some of our team in Nigeria. And I would like to finally say, in order to make a difference, we need to engage with the mainstream media. It's social media, but also mainstream. We need to really go to the level of the population outside the health system. Thank you very much. And I'm sorry for getting over time, but this is one of my topics close to my heart. And I really wish and I hope we can learn from the experience of Nigeria and make a difference. Thank you very much.
Thank you very much, Professor Dina Balabanova, for that very insightful presentation. And we all can actually have an insight into some of those evidences that we're given. So we are moving on to the next presentation, the third presentation for the day, that will be delivered by the Director of Programs for the Yobe State Contributory Health Management Agency, titled Using Data to Improve Health Insurance Operations. And it's going to be delivered by no other person than Suleiman Dada. A round of applause for him, please. You are welcome, Suleiman.
Standing on the established protocol, let me go straight into the core issues to be discussed. But it's also very important to recognize my mother in the house, Mama Lola. Can we please give her a round of applause? Thank you very much. So my topic is using data to improve health insurance operations, but with specific caveat that says the experience of Yobe State Contributory Care Management Agency. Of course, we are delighted on behalf of the agency to be part of this success story of DGI and the health sector in the country. Thank you very much. Okay. Thank you very much. So this is the leader for the state, the governor, who has given us all the opportunity to ensure that we drive the state toward achieving universal healthcare coverage. So this is my presentation outlined. Of course, because I'll be speaking for Yobe State Contributory Care Management Agency, sharing our experience, learning from other critical stakeholders and technical experts here, at the same time, making some key recommendations from our experiences using data. But we are going to look at these outlined for the presentation. Starting with this, it's very important to say the agency is Yobe State Contributory Management Agency. We are established by law in December 2009 to implement the contributory care scheme in the state. And then, of course, with a core vision to ensure effective and efficient path to the attainment of universal healthcare coverage in the state, in line with the global and national agenda. This is our enrollment dashboard as at October 2023, from the time when we started. You can see one of the greatest success story in Yobe is that we have all 4 functional programs in addition to other donor-funded support to the state to scale up coverage, and most importantly for the vulnerable population. We have over 276,000 people in the last 2 years enrolled and accessing healthcare. Quoting from the informal sector program, the basic healthcare, the state-funded equity program, the informal sector, the Bill and Melinda Gates Foundation support, as well as the UNICEF grant that enrolled 10,000 beneficiaries in the state. This is the scheme funding designed in Yobe. This is the formal sector, the equity, the basic healthcare, of course, the informal sector program, the BMGF, and the UNICEF support. One good thing in our commonality is that we try to harmonize our benefit package. We have a single benefit package with the exception of the basic healthcare provision fund that comes from the national level. But all other programs are using a single benefit package, a single service tariff, and a single payment system. We also have all premium at the same price. So now, this is now delving into the core aspect of the presentation. That is how to use data to improve health insurance operations. Now, starting with this very important background and asking these questions. Why data is important in insurance business? Of course, insurance ecosystem all over the world is associated with some key health financing function that include pooling of resources. And to pool in resources, there must be a way in which accountability play a very important role, especially in Nigeria, where most of the health insurance, if you look at the issues around financing in the health sector, and then where a health insurance agency is pooling resources, accumulating these resources, so it can be easily misunderstood in terms of the purposeful drive for implementation of the insurance business. So therefore, to use data to engage the relevant stakeholders is very important, is very critical for the overall interest. Number one, to understand and analyze various performance indicators and scheme designs. Health insurance all over the world is associated with a lot of grievances, particularly from the beneficiaries of the scheme. So therefore, it is very important to understand the indicator that speaks of performance, particularly looking at the exit interview and surveys that focuses on client satisfaction. Otherwise, there will always be a big concern. The service is not good, there is no drugs, and so on and so forth. So data will enable insurance agencies to understand a disaggregated performance indicator for a better delivery of service. And then number two, it can also help to optimize quality operations and customer satisfaction, because there is no way you will improve operations in the delivery in insurance business without data. So the data is very, very important to understand what it entails to say this service is qualitative or this service is not qualitative, or this is a lower quality service. You need to have a clear data to have this understanding. And then of course, insightful recommendation. With data, you can be able to make an insightful recommendation for evidence-based decision-making. I believed there will be a lot of examples to show, but most importantly, recommendations, particularly to political leaders, development partners, and donors, it requires data. And this data, it's very important, especially to guide conversations, including drive for resource mobilization. And then, of course, data is a powerful tool in engaging political leaders all over the world. We need to be speaking to our leaders using data. If you do not have evidence of the services you are providing, after disbursing maybe over 2 billion naira to healthcare facilities in 1 year, you must have a credible, verified, valuable data to engage the political leaders. They may not understand when you say to you have purchased premium, you have done this, you have not done that. But with a data, you can be able to say, this is what you have accomplished, this is how you did it, and these are the how resources has been injected into the system. This is the immediate outcome, and so on and so forth. So engaging political leader require us to have credible data, and credible data comes from a lot of engagement and exercises that happen at the state and all over the country. And then, of course, health insurance agency must have a corporate business objective. Because it cannot be the business as usual public institutions. And for you to have this business, for you to have a corporate objective of as an agency, it is very important to ensure that you have credible data in terms of how to set the agency. It shouldn't be by accident. Once law has been passed, you just moved into, there must be some credible landscape assessment in using specific context to have a deeper understanding of why, how can you set up the agency and drive the core objective of the agency. Can you please return my slides? Let me have the laptop. Right. And thank you, and apologies. We are also saying to achieve financial sustainability as a corporate insurance agency, there must be a data. Without credible data, it's going to be very challenging for institutions like the contributory scheme or health insurance agency to have a sustainable sustainability, especially financial sustainability. And then, of course, insurance is also associated with certain risk. And for you to ensure that you operate a low-risk insurance agency, you must be guided by a data in order to guide you in key important decision-making. Now, starting with the key experience of YSCHMA, especially issues around the client satisfaction survey. The agency embarked on client satisfaction survey to ensure that as an agency, after 2 years, we come to realize there is a lot of continuous growing complaint because there is ill-informed members of the public, particularly among the beneficiaries, around who is responsible. Is it the contributory scheme? Is it the healthcare facility, or who? So to have a deeper understanding, and in order to have a strategic direction toward addressing the problems, we embark on client satisfaction survey, that we try to assess the general knowledge of people around the contributory care scheme. And we also try to have a understanding in terms of utilization of the services at the facility level, including the perceptions of these very important enrollees. And then it follows a normal studies, a survey process that involve this methodology. Now, this methodology, which started with a preliminary meeting, we had a lot of desk review, we worked closely with the DGI team, we have a program, transitioning and development of questionnaire, which was later translated. We got an ethical clearance from the State Ministry of Health. We also tested the questionnaire. Before that, we recruited the enumerators, and then we deployed them to ensure that the survey is successfully conducted. Now, one of the most important and critical lessons and experience that we have learned from the client satisfaction survey is that there are 7 critical indicators of performance or satisfaction by the clients or enrollees. And this satisfaction, it cut across: number 1, receipt of prescribed drugs. Because if you look at it, after 5 to 10 years, political leaders will approach some of these agencies for results, especially in the areas of impact. For you to demonstrate impact, you must be able to show reduction in the out-of-pocket expenditure. And if you want to show reduction in out-of-pocket expenditure, you must be able to understand in a disaggregated manner what constitutes out-of-pocket expenditure in a health insurance business. And one of it, most importantly, is drugs. Because when clients comes into the hospital, the highest resources he expends is in the purchase of drugs after he must have been reviewed and seen by a clinician. So we do not have this clear, it's going to be a problem for us. Understood from this, that certain percentage with the receipt of prescribed drugs after they must have seen a clinician. But of course, this is the biggest worry of Yobe State Contributory Care Management Agency, because in most you go into the facility, they have not got enough either from the clinic or from the healthcare facility. Eye opener. So it has enabled us to have a target. When we reach the facility, there are a lot of sub-delivery points of drugs and medical consumables for the team. quickly engage with the facility to ensure department to ensure that people have received prescribed some other factors. So this dependent population is provided at the state level is the business as usual. Shall we remain implementing the basic care provision fund and the formal sector programs? This is where we are. By 2025, we are still going to have more than 85% of our populations uncovered. And that is not the desire of the state or the desire of the government at the state level. So we have to begin to think very differently. And then we look at the first scenario, which at looking at other opportunities that we have at the state level. And then some of these opportunities are here. I think we can look at it. The last and the most important is the fourth scenario, which I would like to share with us. So this is the fourth scenario, which look at, we have to embark on certain approaches, thinking differently, thinking outside the box. Number one, looking at the available opportunity at the basic care provision fund that will provide as a catalytic fund, looking at the equity programs, looking at other innovative financing sources. So rider to this fiscal space analysis, the agency developed an alternative financing strategy, which the document was validated and was disseminated to the stakeholders that identify other streams of funding opportunities that we can tap in from to ensure accelerated universal healthcare coverage. So this is, for this, we have very short time because of course the technology has also affected our timing. The other one is also outcome indicator survey. The outcome indicator survey is very important for health insurance agency. 2 or 3 years after you commenced operation, there is a need for you to test the utilization of the resources that you are deployed to the facility, whether it is achieving the intended purpose or not. This is very, very important because political leaders will ask questions. The state assembly will ask questions. The governor will ask questions. You have sent over 2 to 3 billion naira. Where is the result? How has that helped the state in terms of achieving universal health care coverage? Looking at specific areas in terms of efficiency in utilization, human resource for health, among others. So we also embark on this very important, we look at these very important outcome indicators. These outcome indicators were generated from the state M&E framework that we have at the state level. Efficiency in terms of spending, the intended purpose to achieve from the resources that has been deployed to the facility, the quality of care. Are people accessing the quality they desire in line with the quality improvement plan? Issues of coverage and access. How far have you gone? How far as an agency? How many people have you covered? What is the target that you have set for yourself? And then of course, issues around equity. So all these things was look at deeply, and then we have a very important key findings, which the findings was also disseminated to the stakeholders. Part of the findings is that you can see it has confirmed that the scheme has enormously contributed in terms of providing efficient service delivery at the facility level, looking at issues around human resource for health, because there is a very huge human resource gap. So the resources through the survey has confirmed a good contributions in terms of employing ad hoc technical staff into the facility to ensure quality service to be provided for the enrollees. And then, of course, we also look at the target in terms of access, where we want to be and versus where we are at the moment, which is also to challenge us to be on top of our game using evidence and data, because these are things that we have to show, because we have a strategic plan for 2021 to 2030. And we are targeting by 2030, we should have 64% of our population covered. Now we are in 2023. We are supposed to have 13% of our population covered, where we are at the moment. So what are we doing? So until the numbers keep increasing, we have to speak with the numbers as an insurance agency to convince our leaders, to convince our partners, and to convince the public that we are doing our best to ensure the drive for achieving universal healthcare coverage. Now, the last example we are going to show is around the financial sustainability plan. Because we are dealing with a lot of insurance risks, it is also important to ensure that we have financial sustainability plan that look at financial sustainability, programmatic sustainability, technical sustainability, and social sustainability without clear figure and data to understand these sustainability approaches. It's going to be very challenging for us to also implement insurance as a business. Now, I think. Now, this is our challenge and our constraint to wrap up. One of the major challenges that we have from the fiscal space analysis is clearly shown here. And then, of course, we also have this, we have a large pool of dependent population. So as an agency, we must continue to have a rigorous resource mobilization drive using alternative strategy to ensure that we pull resources from other sources to ensure that we accelerate the attainment of universal healthcare coverage. And then as part of our challenges, of course, these are some of the noticeable challenges from all the survey, which is very, very important to share with other insurance agencies. Issues at weak financial accountability at supply side. So this is also another key challenge. Until when you test it using survey, that you will understand that the financial accountability at the supply side is weak. We tested it through the client satisfaction survey, through the fiscal space analysis and the outcome survey. And this has shown us the weaknesses at the supply side. We have also confirmed issues around essential drugs unavailability at the facility. This is very important to prepare you for the impact survey that you are going to conduct in 10 years or in 5 to 10 years to come, because drugs is one of the most important indicators for out of pocket until there is availability of drugs at the facility. Otherwise, by the time you come to say you want to do an impact evaluation of the contributory care scheme services, you are going to have a lot of challenges. And the issues of human resources remain still a challenge to delivering quality of service at the healthcare facility. And then finally, as a way of recommendation, we are saying there must be a sustained evidence-based engagement with political leaders to drive resource mobilization for coverage expansion. This is very, very important. And health insurance agencies at this, in some states, is very misunderstood because people just assumed the resource that was accumulated. You have accumulated resource, you have not used it. What are you doing with it? So these are some of the silly questions that some of our leaders continue to face in the insurance ecosystem. But with a clear evidence and strategy, you can be able to speak around why insurance is associated with resource accumulation and utilization. And the issues we must increase focus on data-driven financial sustainability to achieve universal healthcare coverage. Sustainability must be both financial, programmatic, technical, and social. So you must look at it all with a data. How much do you require as an agency to sustain effective operations in the 10 years to come? You need to undergo this financial sustainability plan exercise to have a clear understanding of your resource requirement so that you are not going to have a business failure in time to come. And then, of course, there is a need to develop a nationally broad-based accountability framework for insurance agencies. This is very important. There is an isolated support in terms of driving toward the development accountability framework. But I think we want to suggest or recommend that NHI to take a lead to have a coordinated and unified accountability framework, looking at the state-specific context, looking at various forms of accountability, being it financial accountability, performance accountability, social accountability, and other forms of accountability, so that we're going to have a clear direction in terms of what are we tracking, what are the results are we getting, and how can we improve on what we are getting as a result. Thank you very much for listening. Thank you.
Thank you, Malam Suleiman Dada, for that beautiful presentation that was able to analyze how data can be used to optimize operations under the State Health Insurance Scheme in Yobe State. So for our fourth presentation, I'm very delighted to invite to the podium my very own country director, who is very passionate about using technology to advance universal health coverage. And as she delivers her presentation, please permit me to welcome Dr. Njide Ndili, Country Director, Farm Access Foundation. You are welcome.
Good afternoon, everyone. I'm going to make it short because I realize I'm between you and your tea break. So we've had a lot, and I want to just quickly showcase a few case studies of how we are using digital technology to optimize resources for UHC. First of all, let me give you the landscape. If you go to the next slide, it's always important to understand the entire ecosystem and what drives it. Right now, the reason why we are not anywhere near achieving UHC is because there's no trust in the system. And why is there no trust? You can see all the different factors. Everything is limited, limited, limited. Limited investment and commitment from the state government and from the private sector. Limited quality of care, limited resources and capacity, even for the governance system. There's also fragmentation of financing on the demand side, out-of-pocket payment, and so on. And the result of this is a huge burden on the individual. So you can see the entire ecosystem. So we use this framework when we do our interventions and when we deploy innovations to support universal health coverage. So basically, the demand is unpredictable, so investment is very limited. So if you go to the next slide, you see why there is a need for us to focus. That is, our interventions have to be very targeted. We are one of those organizations that, intervene in the entire ecosystem. And these are some of the things that we do. If I start from the demand side, we help state governments to design their health insurance packages, their premiums, and so on, and other innovative financing mechanisms. Research around some of our innovations to ensure that it has an impact, technical assistance. So when we support states, we always put aside some budget to develop capacity. We give loans. We have the Medical Credit Fund, which is a fund of over $40 million to catalyze investment in the healthcare sector, especially for SMEs. The quality tools that we use, we believe that the supply side and the quality of care that is given cannot improve if the quality of care being delivered is questionable. We also have the equity fund. Then, of course, there's a need to educate the user. How can they also, at the beginning of when I was giving my goodwill message, I talked about digital and mobile technology. So again, we look at all this. with one fundamental principle: how do we improve the trust in the system? For those of you who travel overseas and you go to the bus stop, you're waiting for a bus. When he says the bus will be there at 10 a.m., it will be there at 10 a.m. What we're looking for is a system where you prepay for healthcare, and when you expect to get care when you go to the hospital, and when you get there, you actually get good quality care. That is the kind of system we need to build. And that is why it is important to develop that trust in the system by intervening across the entire ecosystem. So the next slide is just to give you a snapshot of where we are, okay, as Nigeria. As Farm Access, we're in 4 African countries. We're in Nigeria, we're in Ghana, we're in Tanzania, and we're in Kenya. So we took a look at the recently published WHO UHC Service Coverage Index. Unfortunately, you can see where Nigeria is at. I mean, the speaker is blocking my view, but we are performing the least. And not only that, we actually seem to be moving backward in terms of our indices. Some of us, we continue to perform, continue to talk, spend a lot of money, a lot of resources. We pat ourselves on the back that we're doing great work. But actually, the numbers tell a very different story. And we should keep that in mind as we design our programs and as we move forward. So let me quickly go into, if you go to the next slide, I want to focus on the use of technology, because oftentimes it's very limited. We don't pay a lot of attention to it. But I think that the time has come for us to begin to make a concerted effort to embed technology into our systems. One is, these are some of the enablers. Without, and I said it before, and I mean it, without technology, we are not going to achieve universal health coverage. Technology will help you aggregate the funding. There's so much funding in Nigeria. We saw that during COVID, but a way to align it properly is the use of technology. Identifying the individual, I talked about that. We can use mobile phones to identify you and plug you into the system. Lower transaction costs. I know that I don't want to mention any agencies, but normally you want to send a bill, they print it and send it to you. They print the enrollee registers and send it to you and so on. That costs a lot of money, not just in paper, printing, ink, the delivery system. So what if you're using your mobile phone or technology? You don't really have to waste resources on that. Pay for performance, and now value-based care. This is very important because we need to begin to think of how to maximize the funding that we have. Anyway, we all know that Nigeria now has mandatory health insurance law across almost all the states. If perchance all of us are folded into the system today, the system will crash. It will crash. Not only because we don't have enough providers on the supply side, but we don't have the system to manage all the human beings. Right now, we have less than maybe, well, we don't even know, but speculatively, less than 10 million people on the health insurance system, on the NHIA system. Where is the data of the utilization? Where is, the disease breakdown from governance and regulatory bird's eye view? I'm yet to see it. Maybe it exists, but it needs to be aggregated. This is what technology can do for you. With that data, you can now begin to make decisions. How many vaccines do I need to produce? How many drugs do I need to procure, and supply chain management, and so on and so forth. This is why technology is critical. You cannot improve what you cannot measure. Next slide, please. So the next slide just gives you a picture of the current situation on the right, on the left side, where you have lines crisscrossing with the individual in the middle, from the from different donors to different hospitals. I can't even tell where the lines are going. Can you imagine if that was aggregated in the middle, like I mentioned before, either through your app or through technology, so that the funding is streamlined? So for example, you have a wallet in your phone, you have money from Global Fund for TB, HIV, AIDS, it goes into the wallet, insurance goes into the wallet, and so on and so forth. So around the patient, all the funding is aggregated within your reach inside the wallet. You go to your provider, then you can already begin to make payments or seek approval and so on and so forth. That is the efficiency that technology can bring to the space. It will organize the chaos, because right now it is chaotic. There's so many vertical programs, so many different programs that are running. Next slide. Now, I want to talk about a scenario where, we are talking about optimizing resources. Just to talk about what we're doing with NHIA, who is the regulator and a very strategic partner for us. We talk about people not being able to access care, but data has it that in most low and middle income countries, what kills you is the care that you're receiving, not access. You go into a hospital, you get something else, and you come out worse than you went in. So it's important that at least there's a way to even monitor the quality of care that you're receiving. So in support of that, I think Dr. Gada has left, we've been working with him to digitize quite a number of their standards and training their regional personnel, so that with the tools, which are also on the mobile phone, they can go into the field and be able to assess healthcare facilities in preparation for, BHCPF and so on. And right now, there's a bit of harmonization that is going on between BHCPF and NHIA to harmonize the tools. Next slide, please. So I also wanted to give practical example. So it's not that it's happening in private sector, but it's also happening in public sector. So this is data from one of our providers, Pelon Memorial, that has deployed SafeCare. SafeCare is a quality improvement methodology that was developed between PharmAccess, JCI International in the United States, and COSASA in South Africa to improve care within healthcare facilities for resource-restricted setting. So Dr. Onya, who is the medical director, joined SafeCare in 2015. You can see the indices for yourself. Over 180% increase in revenue, 320% increase in patient visits, and so on. The next one is from a government facility, FMC Ebutemeta, which is now very famous, world famous, if I must say. When we started working with FMC Ebutemeta, my assessors went into the facilities and there was a wedu in the fridge that was meant to hold vaccines. I mean, there was, it was very chaotic. I have some of the pictures and it's quite unbelievable. He started by saying no cash policy, everything digital, paperless system from the minute you enter FMC Ebutemeta till the minute you leave. The first casualty was the accountant who resigned. I don't know why he resigned, but you can I'll leave you to guess. But from that moment on, the revenue collection within FMC has quadrupled, to the extent that the hospital has even bought land and they're expanding. I was there about 3 weeks ago with the current Minister for State for Health to look at their cancer center. They're actually putting a cancer center there from internally generated funds. The FMC is the first hospital that I myself have been admitted into in Nigeria since I relocated. And I can tell you that the medical director said to me, go into the facility, you don't need to mention my name. Go there, enter through the emergency room because you have a sprain, and see how the system treats you. I can tell you that my feedback to him was phenomenal. He was asking me what my feedback was, and all I could think of was, okay, there are spiders. I saw a few spiders on the ceiling because all I was doing was looking around the ceiling, but it was efficient. This is a government tertiary institution, and that's the way it should be. Next slide, please. Then I also want to, I needed to put this here because we have a current Minister of Health who believes in the pivotal role of quality. The reason why you don't prepare for health is because you don't believe in the quality you're going to receive. It's a fact. You don't trust the system. But he said this at a conference, permit me, I took it out of a quote he made, I think it was 2 years ago, even before he became minister, and one of the quality conferences, that healthcare access without quality is dangerous and wasteful care. Quality can be an arrowhead for the transformation to realize a different future for health systems in Nigeria and for Africa. So this is very important as we plan programs and move forward. Next slide. Now, I want to change gears to also how we can leverage funding, okay? Using digital technology. As some of you know, most of us here have, family in the diaspora. The first thing they do is say, please send me money. I hurt my leg, I want to use it for care and so on. Ultimately, what do? They buy a car. They don't really use it for healthcare. So we started developing a program called Health Remit so that funding can be sent directly into a health insurance program. We're currently developing that now, but when I was engaging with some of the doctors in the diaspora, the first thing they said to me is, what is the quality of care that you guys are going to give? Because my mom is there, I don't want to pay, then the quality is not good. So we find that we're in a chicken and an egg situation, which we must tackle from all directions, which is why, again, I put up that framework of the entire ecosystem. So this is just an example, because we often talk about the amount of money coming into the country, but how do we maximize it? So you can see the budget. Anyway, this was in 2018. I'm sure it's gone up further than where it is right now. The third scenario, if you go to the next slide, talks about horizontalizing vertical programs. Nigeria is awash with all sorts of programs, rollback malaria, PEPFAR, you name it. Donors are fighting over themselves to fund programs. And all of them are just vertical, and they are replicating structures and very inefficient. What we did in Lagos was we said to Lagos Global Fund, use Lagos State as a test case. Let's horizontalize all these, your vertical programs. Let's strengthen the system for you. They brought me into a meeting where they were planning programs for the next year. And the question was, what are the needs of the CCMs? What do you want to procure? What programs do you have? Of course, first on the list was, we want to buy 10 cars. We want to buy this, buy that. No, and you keep putting money into the system and you're not getting any results. Year on, year out. Go and check Global Fund's budget over the last 10 years. They've spent millions of dollars and we have nothing to show for it. And what we're saying is, please find a way to horizontalize these programs. Support the state health insurance programs, support their systems so that there's sustainability. This is just one example of a tool we developed for them. Nigeria is one of the countries that has the least identification of TB cases. We just took a simple algorithm and programmed it onto a phone and disseminated it to community health workers. Within a period of 48 months, look at the numbers, they speak for themselves. And we were working with the National TB Program, and it's currently adopted in 22 states. In fact, we are in the point of transitioning and backing out of the program because the system is running for itself. What we should be thinking about is, how can we use tools like this that have worked and expand it into primary care or other programs that support the whole person and all systems access to care. Next slide, please. And I think that's the last one. If you go back to, I talked about this before, value-based care. This is also an example where we're trying to direct funding specifically to those who need it. So again, as I mentioned, there are quite a number of donors. This is by MSD for Mothers, targeting pregnant women. And what we say to them is that we will test it, make sure it works, then we'll find a way to integrate it into the state health insurance scheme. Next slide. The last but not the least is what I talk about in terms of public-private partnership. That every party has a role to play. The government has its role as regulation, strategic purchasing, performance management. Private sector comes with its innovation, expertise, capacity, and complementary funding. Now, I want to go into some images. In the beginning, they talked about what was happening in Delta State, and I'm very happy Dr. Ben is here because he championed it. If you go to the next slide, you will see examples of facilities that have been abandoned. And this is common. It's not just Delta State, it's all around. On the left, you can see the facility before, the private sector intervention. On the right, you can see, you know, the transformation. And this is without really government investing in the facility itself. They took a loan from Bank of Industry with some support from the Medical Credit Fund, and the transformation has been phenomenal. Now, I was in Delta State, I think last week or this week, I forget, just to see how we can scale the program. And the compliments were very good in the sense that they have already just 15 facilities and they've seen millions of Deltans in terms of encounters. And you ask yourself, where were they going before these facilities were upgraded? I mean, you can talk to Ben there and get direct experience from him. But this is to tell you that there is no need to build more facilities, PHCs. Any new governor that comes wants to build 10 more or to redesign. Private sector can help you. That way you maximize what you already have existing and you don't have to spend more money, even on human resources, because sometimes they bring their own human resources and the results are phenomenal. I can tell you that in these 15 facilities, there was zero maternal mortality, zero. No woman died trying to give birth. And thank you so much, thank you. No woman died trying to give birth. So can you imagine, only 15, if we had to do this in 30,000 PHCs across Nigeria, our indices would drop significantly. So if you go to the next slide, they're just images because, you know, they're before and after. And I can tell you that those running these facilities, a lot of them were actually outside of Delta State. You have Paylor Memorial taking some clinics, outreach, Dr. Dosekun, Medbury, and so on. So it's all about systems, supply chain management, almost thinking about franchising, where you have standard systems, digital technology, supply chain management to manage a small PHC, just the way you manage a Burger King, if you understand me. This is what you need. These are the resources you need. Then if there's a need for secondary care, you can then refer, and so on and so forth. So next slide, I think, yeah, so basically what I'm trying to say, this is my last slide, is that for us to manage or maximize the resources that we have a lot of thinking to do amongst ourselves. But the number one priority is political will. Political will, without it, you can't make any advancement. We were able to achieve what we achieved in Delta State because Dr. Ben at the time, who was the DG, had direct access to Dr. Kowa, Governor Kowa, who is also a medical doctor. So he was able to implement without restriction. I don't know about other states, but it's important that whoever is empowered in the agency, in the ministry, whatever portfolio you're holding, you have the authority to make decisions that are in the best interest. We talk about governance structure, very important. Institutionalizing quality. There is a direct link between quality improvements, revenue generation, sustainability, and so on. Without quality, we are conducting wasteful care, according to Dr. Patti. Then the use of technology, you can't improve what you can't measure. And last but not the least is bring in private sector. Private sector can support. Private sector can help build capacity. And with that, I will end saying that we have a lot of work to do. Like I said, when I started, you know, we keep coming back, we keep talking and talking and talking. But I think now is the time really to begin to act. Otherwise, 2020, we will still be where we are today. Thank you very much.
Can we please appreciate my country director again? I'm sure we can all learn from what we are doing at Farm Access Foundation. We came way before our time. And of course, even if we say that technology has demerits, we can see the merits when we institutionalize technology in advancing healthcare. So on this note, we want to take a short break to have our tea break. Please, I'm urging everybody. We are going to have a very short break of 10 minutes. Let us please stick to time so that we can close early. Thank you very much. 10 minutes starts from now. Thank you.